Hi, this is Katie again with Far Northern Regional Center, here to discuss dementia, specifically in individuals with intellectual disabilities and with an emphasis in Alzheimer's disease, as it is the most prevalent form of dementia that you will likely encounter in your career. So, just a little bit of a background on proteins, which is significant to basically any form of dementia. So, proteins are required for all or the majority of biological processes in the body. They each have specialized functions, and their structure determines their function. They help aid in the production of neurons, which are cells inside the brain, and they help neurons communicate with each other as well as receive communication from the rest of the body. Neurotransmitters are a chemical in the brain that help neurons communicate with each other, and they're composed primarily of amino acids, which are the building blocks of proteins, or also neuropeptides, which are kind of an in between the amino acids and proteins. And proteins also are necessary for energy production, not just in the brain, throughout the entire body. But since we're focusing on dementia, we'll be focusing specifically on their function in the brain. Proteins can be either an enzyme or a hormone. They could also be utilized as an emergency fuel for like better or for better lack of terms, I guess. Once you burn through carbohydrates and fats, proteins can be broken down for energy. It's not the best way to get energy, but it is kind of like an emergency backup. So enzymes help lower the amount of energy that's needed to create biological processes. So they're really important, and hormones are a communication signal between cells. So as I mentioned, proteins, their function is determined by their shape, and their shape can be altered. They have a very narrow range of functionality. So if they get too hot, their shape can change, and they can also change permanently. If they're in an environment that's too acidic or too basic, it will also change their shape and change the function. Mechanical agitation will also change a protein. If exposure to chemicals or solvents can also change the shape of the protein. Now, this shape change could be reversible. It might not be. Think of it like an egg white protein. When you apply heat, it solidifies. You can't bring it back to an egg white. But with some proteins, they can become very cold, and their shape changes, they're no longer functional, but when they warm up, they can go back to doing their correct function. So the important thing I want you to pull from this is that when proteins are misshaped, they lose their function, and sometimes they can actually cause problems beyond not being able to function. So moving into dementia, it is a condition characterized by memory loss and loss of cognition, which will interfere with daily life. And there are several forms of dementia. The most common are neurodegenerative dementias. And as I mentioned, Alzheimer's accounts for 60 to 80% of neurodegenerative dementias. Also in this category are frontotemporal dementia, which affects mood and behavior. There's also Lewy body dementias, which includes Parkinson's disease. And then another category are dementias caused by prions, such as Creutzfeldt-Jakob disease. So prions are a result of a misshapen protein, and they can cause direct damage to the neural tissue. Vascular dementias are the result of changes to the vasculature inside the brain. This can happen if somebody has a stroke, where there's a loss of blood supply to part of the brain, which would cause cellular death. And it can also happen from narrowing of the blood vessels of the brain. So not necessarily having a stroke, but if there's a lot of like cholesterol or plaque buildup within the blood vessels, that severely restricts the amount of blood and oxygen that can get to the brain cells, and cause death or it can result in like burning up proteins for energy because there's just not enough glucose metabolism happening, and that can build up toxic chemical or substances, which can cause injury to the brain. Um, so these dementias usually cause dysfunction, like an executive dysfunction. So, um, sorry, I'm losing my train of thought for a moment. Um, and then it does tend to have like a step-like progression. So it's not a gradual decline. Someone will have a sudden change in their ability, and then they'll be fine for a little bit. But then if they have another like cardiovascular event, they can have even further decline. This can also result in changes to physical abilities, changes in behavior and mood. It's generally progressive and irreversible. And that is also the same for neurodegenerative dementias. Um, and it can also reduce the ability of someone to be able to process information. And then the next form of dementia I want to discuss are mixed dementias, which are basically exactly what they sound like. They're a combination of one or more, or of two or more dementias. So someone could have Alzheimer's disease, but they also have dementia as a result of a traumatic brain injury or, a stroke. Um, and it's really hard to parse out specifically what dementia is causing which symptoms. And sometimes maybe somebody only has a diagnosis of Alzheimer's, but after they've passed, they found on examination of brain tissue that the person also had vascular dementia as a result of a stroke, but that was masked by the Alzheimer's. And then there are also reversible dementias. So common causes of a reversible dementia is medication. It could be a result of improper nutrition. It can be an issue with the body's ability to metabolize substances, or it could be an issue with the endocrine system. It can be the result of infection. It could be a result of structural changes, such as pressure on the brain in cases of hydrocephaly, or if there's a tumor in the brain, or if there's a brain bleed. Those are dementias that are oftentimes reversible. For example, if it's a medication causing the dementia-like symptoms, cessation of that medication will generally improve the patient's condition. Same thing with like mental health that can cause the appearance of a dementia. And once the client or the individual's mental health is stabilized, um, the dementia could either resolve or, just be stabilized at that point rather than progress. And then as far as secondary dementias, this is a dementia that is the result of another disorder. So common causes for reverse or secondary dementias are changes to the brain structure, infection, endocrine disorder. So very similar to the reversible dementias. You also see it with the substance related issues like methamphetamine use. Chronic alcoholics usually will develop a buildup of ammonia in the brain, which can cause dementia. And some autoimmune disorders like multiple sclerosis can result in secondary dementia. So moving on I want to talk about two specific proteins that cause significant damage that results in dementias. So the first is the amyloid plaque. So this protein is a result of a misfolding of multiple types of protein. And what happens is when it misfolds, the shape is of course altered and they tend to be sticky and they clump together and they form around neuron cells, like on the outside of the cell, which disrupts the transmission of neurotransmitters, and it also can cause cellular death. And it's not fully understood how the damage occurs, but it appears to be, of course, blocked neural signals, and it also can result in inflammation, which is, um, kind of like sometimes swelling in the area, which can result in edema. So it's uh, the body's response to an insult, I guess you can call it, biomedical insult. And it can release free radicals. Those are those are the result of biological processes. Um, they're like the end product of a process. And if they don't have um, another substance to bind to, they can bind to the cell or bind to like DNA and pull that information apart and cause problems. Um, Also, cytokines, and again, the swelling, edema, and the autoimmune response can actually cause the body to attack the brain cells and damage or destroy the cells. The next protein I want to talk about are the tau proteins. So these are actually proteins inside the neural cell. They actually are structural and they help move the neurotransmitters from one cell to the other. So they're really important for communication. Um, what happens is when these cells are misfolded, they end up becoming these tangles, and it disrupts the ability of the cells to communicate with each other. It also disrupts the ability to send necessary chemicals from one cell to the other. So not necessarily communication, but like building blocks that are needed for cellular function. And of course, this can lead to cellular death. So moving into Alzheimer's. So Alzheimer's is the result of shrinkage in the brain, an enlargement of the ventricles, which is the space that you can kind of see in the middle of this brain here, and then shrinking of the hippocampus. And that is a portion of the brain that is responsible for a lot of, I guess, basic necessary body functions. And as you can see, when a person is experiencing very advanced Alzheimer's, there is a lot of shrinkage and a lot of loss of brain tissue. So there's a loss of capacity as a result of that. When it comes to diagnosing Alzheimer's, it's really important to work with a provider who specializes in neurodegenerative disorders in order to rule out other conditions. Because the source of the dementia or the appearance of dementia really is going to drive treatment. And if someone immediately jumps to Alzheimer's, they could be missing a reversible cause of the dementia. Um, so it's really important for the provider to be familiar with diagnosing Alzheimer's so that way they can rule out appropriately other possibilities. And they do that by investigating the cause of the memory loss. And this also, part of that is interviewing people who are close to the patient to better understand when symptoms started. Did something happen around the start of symptoms? Has this been gradual? Was this a sudden change in capacity? And then also utilization of imaging studies such as MRI, CT, or PET scans can help visualize any structural changes in the brain that can signify a dementia. And as you can see in this image, there is a significant comparison or difference between what you would expect to see with a normal brain versus the brain of an individual with Alzheimer's. And this image was done with a PET scan. Um, Part of, again, the diagnosing of Alzheimer's is taking that thorough medical history, doing a physical examination of the patient, conducting a neurological exam, and also testing cognitive, functional, and behavioral um, components or behavior functions. Um, and this is not just a one-time appointment. This is something where the provider is going to see the patient on an ongoing basis so they can document and visualize a progression of the disease. And that will give them more information about what they need to do for treatment. When it comes to risk factors for dementia, there are modifiable risks and then there's the non-modifiable risks. So the ones that you can't change, aging. Part of the aging process is um, the body doesn't work as well as it used to. I'm sure you guys are all familiar with how that works. Um, and as a result, in the brain, like it's more common for proteins to start misfolding, or not being appropriately cleared. So our body is always misfolding proteins. Like it's just part of our biological makeup. Sometimes the protein is coded incorrectly, and so it's going to fold incorrectly. And normally, what happens is the body is able to dispose of that either by using cells that are going to, like, for lack of better terms, eat that misfolded protein. Other proteins can transport a protein that they see as incorrect into the bloodstream, and then that can be pushed out through the natural filtration system. And then there's also in the brain, the glymphatic system. So this is part of the cerebral spinal fluid that goes through the brain tissue, and it takes away a lot of that cellular waste, which is, free radicals or misfolded proteins. And this system, the glymphatic system, is most active when you're asleep, which is one of the things that I wanted to talk about here is poor quality of sleep over an extended period of time will significantly or can significantly increase your risk for developing Alzheimer's disease. But it also kind of is based on, do you have multiple modifiable or non-modifiable risk factors? Of course, the more risk factors that you have, the more um, not likely you're going to develop Alzheimer's, but the greater your risk of developing Alzheimer's is. Um, and when it comes to genetics, a lot of people have, or not a lot of people, but some people have a genetic predisposition to Alzheimer's, especially when, going back 2, 3 generations, family members um, have developed Alzheimer's. That means that gives you a greater risk of developing it yourself. Also, biological sex can be a contributing risk factor. They have found that women are more likely to develop Alzheimer's than men. Um, when it comes to modifiable risk factors, cardiovascular disorders can increase your risk for developing Alzheimer's. So making sure, if you have high blood pressure, taking medications that are necessary, modifying diet to help lower blood pressure. If you have a sedentary lifestyle, increasing daily activity so that way that helps lower blood pressure. Also, other forms of heart disease like hyperlipidemia, which is an excess of like the low density uh, lipids in the bloodstream, which can build up and form plaques. Um, Diabetes, they're finding, is actually a very significant determinant in developing Alzheimer's disease. And I will talk about that again in a little more detail in just a moment. And again, as like I mentioned earlier, head trauma can increase risk of developing Alzheimer's later in life. Depression, life and lifestyle choices can also increase risk. So with depression, it's really important to make sure you're managing that, like mental health conditions, to help prevent or decrease risk of developing Alzheimer's. When it comes to lifestyle, they have found that smoking, poor nutrition, heavy alcohol consumption, and a sedentary lifestyle all can contribute to an increased risk for development of Alzheimer's. And what they have found in regards to diabetes is that insulin resistance in the brain significantly increases the risk for Alzheimer's. So that insulin resistance, what ends up happening is the cells in the brain are not able to bring glucose into the cell as readily as if someone who does not have insulin resistance, which of course decreases the cell's ability to produce energy um, from the glucose. So it's going to start breaking down fats in the brain. It's going to start breaking down proteins because it needs the energy to function. So it's going to start breaking down substances that aren't intended to be used for energy, and that's going to produce byproducts that are going to increase risk for Alzheimer's. And they have found that individuals with type 2 diabetes or any other insulin resistance. Can I please have whoever is not muted mute themselves? I am not sure who that is, but could you please mute yourself?
I love you, Dad. Katie, you muted yourself.
Katie, if you're speaking, you're on mute.
You're muted, honey. I keep asking to unmute. I need you to unmute yourself. It won't let me unmute you.
Okay, I actually didn't even hear you. I thought I had been asking somebody else to mute, and apparently I didn't.
I was
I
muting
apologize.
everybody. Sorry, that was me.
Okay, I get it now. Thank you. Where did we lose me?
You were talking about insulin resistance and how the cells can't use the sugar because of it.
Okay. And so when they use a secondary source such as the fats and proteins, there is a buildup of byproducts from that process that aren't supposed to
Oh.
be in the brain. And so they don't get cleared as readily, especially with someone who is older, that tends to build, it can build up and cause cellular death. And as I mentioned earlier, inflammation can also cause uh, inflammation from di diabetes and insulin resistance can result in cellular death. So moving into how does dementia, specifically Alzheimer's, affect our clients with intellectual or other developmental disabilities? And for the majority, the occurrence is basically the same as it would be with somebody who is neurotypical, but there are exceptions. Individuals with autism, they have found recently, are more likely to develop Alzheimer's than the general population, and same for individuals with Down syndrome. So I wanted to talk a little bit more about how specifically this affects our clients. So, in regards to autism, the current research is showing that individuals with autism are at a almost 2.5 time increased risk of developing early onset dementia or Alzheimer's than the general population. And they believe this is because of genetic links between autism and degenerative conditions of the brain. They're finding more and more genetic or changes of the base genome of individuals. Like if there's alterations in their chromosomes, people have a predisposition to developing Alzheimer's, autism. And a result of also those genetic changes can lead to Alzheimer's as someone ages. And they have also found that individuals with autism are at increased risk for early shrinking of the hippocampus. And that is the part of the brain that regulates emotion, memory, your ability to navigate your body through space. Um, and then also, they have found that this is the one of the first regions that's affected in any dementia. And they have also found that individuals with autism have an increased prevalence of fibrillary tangles. So that's like the tau tangles that I had mentioned earlier. They're not really sure why there's an increased presence of these tangles in the brain, but that is what the studies have shown so far. And moving into a discussion about individuals with Down syndrome, studies have shown that early onset Alzheimer's is fairly common in individuals with Down syndrome. Um, Individuals may be diagnosed as early as 35 years old, but the average age of diagnosis is 55, and the average age of death is 60, which is pretty accelerated in comparison to the general population. And there is a specific reason for that. So they have found that the genes that produce amyloid plaques um, are found on chromosome 21. And as you know, with our clients with Down syndrome, they have three copies of that chromosome rather than the two um, that, are is the standard, I guess. Um, because there are three copies of the gene versus just the one or just the two, they actually have an increased rate of the plaque development. which means that they have an increased risk of early onset because they're going to accumulate more of those plaques faster than the neurotypical individual. And because it's more rapid, that means that the progression of the disease is going to be faster than the general population. When looking at the presentation of someone who has early onset or the early stages of Alzheimer's, um, this presentation that you would see in your client can easily be dismissed as not necessarily cognitive decline. It can be what they, I guess, insidious. Like it's just you don't necessarily notice the changes because they are very gradual. What you might see in a client is they start having a decreased interest in things that they used to enjoy. If they used to like going outside for walks, and all of a sudden they're like, no, not interested, don't want to do it. That could be, I mean, it could be, of course, anything. It could be depression. It could be a lot of different things, which is one of the reasons why, as I had mentioned, a specialist would want to rule out any underlying conditions. Um, but when you start seeing an accumulation of these sorts of presentations in your client, that should be a flag that you mention this to their provider. Next time you go into an appointment with your client, if the client allows, it's a good idea to say, "Hey, we're starting to see this in our client." Um, if the client is beginning to have a decreased attention span, not able to stay on task, or if you're noticing any other mood changes, increased frustration, increased aggression, those can be signs of not just early or like the early presentation of Alzheimer's. A lot of the times when someone has those frustrations and becoming easily agitated, it could be a result of they can't remember something that they used to know how to do. And that's really frustrating. So being patient with your clients when they're having these sorts of changes is really important because they're already super frustrated. And then just mentioning that to their tour provider and also having, gentle conversations with your client. Hey, you seem like you're frustrated. Do you want to tell me more about what's going on? And if they don't want to talk about it, that's fine. Sometimes talking about it can make it worse. But giving the client an opportunity to have that conversation with you is really important. If you're seeing increased restlessness, not able to keep still, or new sleep disturbances, new onset seizures, new onset falls, or increase in falls, or if you see new onset language impairment. So any new change is really important to mention. Um, with the general population, usually one of the first things that people say is like, I'm becoming more forgetful. I'm forgetting things I normally would remember. Um, or I'm starting to have um, periods of incontinence. For some of our clients, that's baseline. So you really have to look based off of how they've historically been and what changes you're seeing past then or past that point. You can also see increased periods of vocalization or excitability. And then moving on to kind of like the mid stage of Alzheimer's, you may see a change in the client's ability to complete their ADLs. They might be struggling more with brushing their teeth or getting changed. There can be changes to their memory. They don't quite remember how to do things they used to do frequently. They may become disoriented more frequently. And I'm sure we've all had that experience where we walk into a room and we can't remember why we went in there. And it's similar to that, except it's on a new level. Um, say you have like a specific route that you take when you're driving home. You can remember the big way or, the major traffic areas. Like I take this highway to this exit, I get off at this exit, but then you forget where you're supposed to turn from there. And that's something that you've been doing your whole life. Those sorts of changes in memory are really important to mention to a provider. Any loss of language. Um, if someone is having an increased inability to find their words, having an increased inability to express themselves, this is also something to make note of. If they're having trouble recognizing people that they've never had a problem with recognizing before, that's important to also take note of. Impairment in judgment. A lot of our clients are all like may have significantly impaired judgment as it is. But if you're seeing anything beyond that, of course, make note of. And again, increased behavioral and mood changes and increased physical changes. They might, of course, have increased issues with incontinence, increased issues with swallowing. They start choking more frequently, or breathing in liquids more frequently. Unfortunately, part of the problem with Alzheimer's is it doesn't just affect memory and your ability to retain information, or your ability to retain information, your ability to process information. It can also affect the very central parts of your brain that tell your body how to do certain things. So your body starts forgetting how to swallow. Those cells forget, or those signals start getting like mixed up, confused, blocked. So you might see the development of inability to swallow, or motor impairment, weakness, falls, increased instability, that sort of thing. And in this image here on the right, you can see the comparison between a person with a mild form of Alzheimer's versus a mid-stage presentation. And in the middle, you can see the ventricles there are significantly larger. And what doesn't show as well in this image is there becomes a significant increase of white matter in the brain, which decreases function. And into late presentation Alzheimer's. So this is when an individual has severe impairment of their memory. They're requiring assistance, or they're dependent on other people for all of their ADLs. They need to have someone help dress them, bathe them, brush their teeth. And again, for some of our clients, this is normal, but maybe they're no longer able to provide assistance, like helping put their arm through a sleeve. That could be an indicator. And at this point, generally with someone who's late stage, there's already a diagnosis in place. It's pretty obvious by that point that the client has Alzheimer's disease or another form of dementia. And again, there could be increased immobility to the point that they're not able to move, like get up and move around at all anymore. They're completely dependent on someone for transfers, or even rolling over in bed. Sometimes they need people to come in and help move them because their body is not sending them the signals that they need to move and take pressure off of their coccyx or their hips or their elbows. So it's really important to keep an eye on our clients who have progressed to this stage to help prevent further injury. And they may have, again, difficulty chewing and swallowing. And a lot of the times, this results in aspiration. So we see a lot of our clients who've gotten to this point, repeatedly going to the emergency room for pneumonias. And frequently there becomes a discussion about G tubes and placement, other forms of artificial nutrition, discussion about end-of-life care. And then full incontinence is very common at this stage. But again, some of our clients, that's baseline, so we can't really use it as a marker. So when it comes to talking about prevention and protective factors, there are a lot of modifiable lifestyle changes that a person can make to help not necessarily prevent Alzheimer's, but slow the progression of the development of Alzheimer's or decrease their risk of developing Alzheimer's. So incorporating these changes or helping support, advocating for our clients these changes in lifestyle, just to kind of help decrease their risk of developing dementia, or at least delay the onset if someone is more likely to develop it than not. So regular physical activity is really important. At least 7 to 8 hours of quality sleep each night. And again, that gives your brain that chance to get rid of those misfolded proteins through the cerebral spinal fluid. The diets that are rich in omega-3 fatty acids and antioxidants. So this would be like the Mediterranean diet or the MIND diet, which is a cross between the Mediterranean diet and the DASH diet, which I'm not sure if you're familiar with the DASH diet. That is a diet for improved cardiovascular health. And the focus for the Mediterranean diet is based off of eating a lot of like leafy greens, um, focusing on using healthy fats like olive oil, limiting processed foods, sugars, and red meats. And then the DASH diet focuses like on basically the same, uh, I guess the same standards, but also, in decreasing sodiums, that sort of thing, excess salts. Um, and then and one of the reasons why we also want to include the antioxidants is that helps reduce the number of free radicals that can cause damage in the brain. Foods that are rich in antioxidants are things like blueberries, dark chocolate, nuts. Um, and I know that there are supplements that are touted as being, full of antioxidants that can help reduce this, but important thing to consider is, a blueberry is going to have fiber in it. It's going to have water in it. It's going to have a lot more in it than just the antioxidants. So whenever you can get it from a fresh food source, that's the best. Increasing social interaction, especially between peers, is really important. It helps delay the onset of dementia or Alzheimer's. And this is by actively engaging the brain. Um, you're I don't know if movement is the correct term I want to use, but that activity in the brain helps preserve function ongoing. Same thing for cognitive engagement. And by this, I mean, puzzles or like a jigsaw puzzle or a word puzzle or anything that put someone in a position to do problem solving. This helps engage the brain and reduce the risk of dementia, or at least delay the onset. Early treatment of hearing and vision loss. This is important because individuals who lose their hearing or begin losing their vision are not able to engage as I really apologize. I hope you guys can't hear my dog walking around. Individuals who lose their ability to engage with others, they can't hear the conversations that are happening around them. They can't see the activities that the team or the group is participating in. They're more likely to withdraw from the group settings, and that lack of stimulation in the brain can increase the risk of developing dementia. And as mentioned earlier, cessation of smoking, limiting alcohol intake, as those are risk factors for developing dementia. Of course, limiting those or stopping those behaviors, I guess for a lack of a better term, will help decrease risk. And then again, managing chronic conditions such as high blood pressure, high cholesterol, diabetes, depression, that also will decrease risk and help protect a client. When it comes to treatment and management of Alzheimer's, there are 3 classes of medications that are generally prescribed for the treatment, or at least the slowing of the progression of Alzheimer's. So the first, I do not expect you to remember the classes because it's a lot. So the first generation of medications were the cholinesterase inhibitors. And so that's medications like donepezil, which are geared towards slowing down the progression of Alzheimer's. This is one that you're probably very familiar with. It was originally approved by the FDA in 96. The next medication that came onto the market were the NMDA receptor antagonists. Basically the same goal is to help slow the progression of the disease, but it works on a different pathway. And it is more for like the moderate to severe forms of Alzheimer's. Now, this third category is relatively new. It's really exciting. It has its own issues, but so this is the anti-amyloid immunotherapy. So this is an infusion. There are 2 different brands or 2 types of the medication. And the first that came out was, and I'm going to butcher the name of this, the lecanemab, which was approved in 2023. This medication is approved for the treatment of early um, forms of dementia or early Alzheimer's disease. And the reason for this is this substance actually breaks down and removes those amyloid plaques from the brain, and it actually can reverse the damage caused by these amyloid plaques. The reason why it's only approved for early Alzheimer's treatment is because these amyloid plaques also um, wrap themselves around not just the nerve cells, but also blood vessels. And they have found that, individuals with more advanced forms of Alzheimer's, of course, have more plaques. And the breaking down of these plaques can sometimes result in the breaking down of the blood vessel or the nerve tissue that it's wrapped around. And they have found in individuals with more advanced forms that this treatment can actually result in cerebral hemorrhage and death. So it is still a work in progress, but it is providing a lot of hope for the treatment of individuals who are predisposed to Alzheimer's. If they have a genetic predisposition, the using it more as a prophylactic treatment than actually waiting until someone is diagnosed to treat. Because usually by the time someone is diagnosed, they've moved into, middle presentation because the early presentation of Alzheimer's can easily be written off as just, normal part of aging. Another area that treatment is focused on are behavioral symptoms. Again, like as I had mentioned, the hippocampus is one of the first areas of the brain that's affected by Alzheimer's development. And of course, that can result in behavioral changes, increased aggression. So like using behavioral modification therapies can be effective, of course, to an extent. Because this is damage to the brain, it's a lot harder to rewire and learn new habits. So often you will see antipsychotic medications or anti-anxiety medications being prescribed to help with severe behavioral changes. And again, treating comorbidities. So that's making sure a person's blood sugar is being managed appropriately, so that way their the cells can get enough glucose into them and function properly. And then also increasing engagement with our clients is really important. So, our clients were able to go to a program. It's really important for them because that helps keep their brain active and helps keep them engaged. And the longer we can support our clients in those activities, the better we are doing for them. And even if our clients aren't able to go to program, sitting down with the clients and, doing a puzzle with them or, talking to them about their day, any form of engagement is good. Reading a story together or listening to music together. Even just listening to music is really big for helping preserve memory and function. So when it comes to supporting our clients, there can be a lot of push to try and reorient someone with Alzheimer's. They may say, I want to talk to Susie, and Susie's their mother who died 20 years ago. Telling the client that, don't you remember your mom passed 20 years ago? Probably won't be the most helpful because in their mind, that hasn't happened. So rather than try and make sure somebody is aware of the reality, you don't necessarily have to reinforce that, oh yeah, we'll let them know that you wanted to talk to them. You can change the subject. You're like, oh, that's cool. That's good to hear. And then just change the subject. So that way you're not necessarily engaging in that, but you're not aggravating the person. So focusing on the now versus, everything else is really important, staying in the moment. Changes in routine can be devastating to someone with Alzheimer's. they have found that individuals who have Alzheimer's, who were living on their own in the home that they've lived in for 30 years, they were doing pretty good. I mean, there were definitely some issues, which is generally why they end up getting placed in a different facility. But as soon as they move them from a familiar surrounding to a new routine, a new home, they lose a lot of their functionality because they don't have the supports that they're used to surrounding them that help reinforce old memories. Their routines change, so they get lost a lot easier. So trying to keep a routine for our clients, and if at all possible, to help keep them in the same home that they've been living in for however long, really is helpful for these individuals. It's also really important to be cognizant of client preferences, helping support their independence is for as long as you can, because it's really frustrating when you start losing the ability to do things that you've always been able to do for yourself. So trying to help support your clients as best you can to maintain or helps them do as much as they can for themselves for as long as possible is really important. And then being patient with yourself and with your client is really important because it's really frustrating for everybody. Um, so just remembering to, when you're frustrated, to take a moment to try and, reorient yourself, um, and just accept that this is a big change. It's really difficult, um, and that you need to be patient with yourself, be kind to yourself, and everyone's going to get through it. And when it comes to long-term planning and supporting our clients when it comes to planning for Alzheimer's disease, or dementia, or just end of life in general for any client, whether it's dementia related or not, is making sure they have a PULSE or an advanced directive in place. So a PULSE is a physician ordered life-sustaining treatment where a person can indicate whether they want to be a full code, partial code, they don't want to be resuscitated if their heart was to stop and they were to stop breathing. It's really important that we have these documents in place, because they speak for our client when the client can't speak for themselves. The advanced directive is similar, but it also gives the client an ability to designate an alternate person to make medical decisions for themselves, if they're not able to do so for themselves. And this is important, not necessarily just for someone who can't speak for themselves. Unfortunately, a lot of our clients, when they make it into a hospital, their provider may see, a developmental disability on their chart and think this person can't consent for treatment, even though they're perfectly capable. So making sure that we have their wants and wishes documented that we can provide to doctors in acute care is really important. And then when it comes to identifying alternative decision makers for the client, make sure that you have that information on file and easy to access. And then verifying and reviewing with the client, reviewing or verifying with the emergency contact that you have the most up-to-date information. Sometimes we put down an emergency contact and never check it again, only to find out the emergency contact died 5 years ago, and now we don't have anyone to reach out to. So just having that conversation with your client while you're able to, and then documenting what their wishes are can be really, really helpful. And I know some of our clients do not want to talk about death, and that's understandable and that's fine. They don't want to talk about end of life. But if you can like gently have that discussion about, hey, is there anyone that you would feel comfortable like helping you make decisions while you're in the hospital, or if you're sick, or if you're having trouble making a decision, is there someone you would want to help you make that decision that you would trust them to um, make the decision for you that you would most want? Um, that's a really good way to have that conversation without necessarily bringing death and dying or inability to care for oneself into the equation. And that's what I mean by get creative on the slide. Sometimes it takes just kind of tiptoeing around the subject, asking a question here or there. But anytime you get information from the client about what their wants are, make sure it gets documented, make sure it's shared with people who might also need to be involved in that decision-making process. For example, if the client gets a post signed with their provider, or they create an advance directive, making sure that their service coordinator has a copy of that in the event that it's needed by healthcare agencies in the future. When it comes to an advanced health or healthcare directive, the regional center is able to refer our clients to the Alice Carroll Foundation, and they will help the client create an advance directive, designate support personnel or persons, powers of attorney in a way that is geared toward individuals with developmental disabilities at their level. And they can also help determine whether the individual has that capacity to make that decision. And if they feel that the client doesn't have that capacity and we don't have individuals identified to make decisions for the client in the event of an emergency, it becomes really important to start talking about, okay, how are we going to support this client ongoing and make sure that if an emergency happens, we already have a plan in place, whether that we need to look at conservatorship or other forms of supported decision making. It's important to have that conversation way before we actually need to have that plan in place, because it never seems like it's going to be it seems like it's going to happen in a ways away in the future, and sometimes that creeps up on us a lot faster than we ever thought. So just a really important thing to take into consideration for our clients, especially when they still have the capacity to make decisions for themselves. So I know that was a lot of information and hopefully useful. Does anyone have any questions? All right.
I don't
It
have any
sounds
I don't have any questions, Katie, but I recently took a dementia course in renewing my administrator certificate, and I have to say they didn't teach as much about the medical side of dementia, so I feel this was a really important class because there is a lot of medical factors. So thank you so much for your time, and thank all of your clinical team for putting together trainings like this.
thank you so much for the feedback. I really appreciate it.
Absolutely. Have a great day.
You too. And if anyone has any questions later on, feel free to reach out. We have our contact information here. But again, thank you so much for joining us today. I really appreciate it.